So thank you very much for the invitation. I'm really sorry not to be among you today to present this study. So my name is Fabrice Jollant. I'm actually not in France. I'm in Germany, where I'm an invited professor, but I'm also a professor of psychiatry in Paris, and I'm affiliated with the academic department of psychiatry in Nîmes, in the south of France, where they started, where the study started, and with the McGill Department of Psychiatry in Canada. So I have no conflict of interest to disclose. We're going to speak about suicidal behavior, just to remind you that 700,000 people die from suicide in the world each year. Suicide is the second cause of death among young people, but the highest rates are usually found in old-age males. 10 to 20 times more people attempt suicide, and after a suicide attempt, around 60% will reattempt in the following year, and approximately 1.5% will die from suicide. But they will also die from many other causes. There is a high mortality risk from natural causes among suicide attempters. The prevalence of suicidal ideation in the general population is quite high. So in France, it reaches around 5% of the population, and up to 10% in adolescents. The problem is the transition from suicidal ideas to a suicidal act. So depending on the study, depending on how you measure it, and depending on the population, it's approximately 25 to 50% will transition from ideas to an act. But the problem is the prediction of the transition is very poor and very weak. When it's only based on risk factor, it's just above chance. And there is a very high variability between individuals in the pathway from ideas to acts. So the idea is clearly to be very conservative and to assess and treat all people with suicidal ideation. So what can we do in the case of a suicidal crisis? There are many things we can do. And before speaking about ketamine and fantastic results about the rapid decrease in suicidal ideation, I think it's worth taking a little bit of time to remember that there are many things that can be done and many things that unfortunately are not done often in many places. The first thing is to improve the identification of the suicidal crisis. There is a large literature showing that professionals, including professionals in mental health, do not feel confident about asking about suicidal ideation. And some may have the wrong idea that asking about suicidal ideas will give suicidal ideas to the patient. So we need good, very practical training, and it's time consuming. There are initiatives that are also interesting, like first aid in mental health that could, in the general population, that could increase the identification of people with suicidal ideation. And there are also national phone numbers. In France, we just opened a national phone number last September. It's very, very successful. The second question is a choice of setting. Where should we treat this patient in a suicidal crisis? It's often a complicated choice. Depends on many things, including the availability of local bed or care facilities. Hospitalization is often the first choice in the case of severe suicidal ideation. We should be clear that it depends on where you refer or to where you refer your patient, because the risk of suicide is high at psychiatric hospitals. So this clinical department needs to have a prevention strategies with team training, restriction of access to lethal means, different procedures. And you can also treat patient as an outpatient in an outpatient facility, but it needs experience and training, and the involvement of the patient and relatives. And then we often give symptomatic treatments, anxiolytics, hypnotic sedatives, and there is clearly no strong scientific evidence of benefits on the prevention of suicidal act. There is actually some proofs of an increased risk of acting out with benzodiazepine. We have a paper in prep with collaborators from Bordeaux in France, showing an increased risk following first intake of benzodiazepine. Sedatives are poorly tolerated. Of course, we need a good assessment and an adequate treatment of mental disorders and psychosocial issues. So whether pharmacological, psychotherapeutic, we should not forget the somatic aspect and social, familial, and professional. Post-acute phase is a very sensitive period, of course. We clear evidence that the first week to the first 6 months after hospitalization, there is a high risk of suicide. So after discharge from a psychiatric hospital. And there are different things that can be done, from safety plan, patient's education, etc. And in the long term, also we need to work psychotherapeutic level and etc. to prevent relapse. So this long slide just to highlight the fact that ketamine will have a place. We need to determine which place it will have in this strategy, but it will not be a panacea that will replace a lot of things. It will probably replace, and I hope it will replace, symptomatic treatments and some of the treatment of mental disorders, depression. But we need to continue our efforts on all other aspects to prevent suicide. Right, so what do we know about ketamine for suicidal ideation? There have been several reviews of literature. I just took this one by Katharina Witt, Keith Houghton from Oxford and colleagues. They reviewed 15 RCTs, 572 patients. There is clearly some proof of efficacy in the short term, which is below 3 days, much less after 3 days. But they highlighted several limitations. So almost all studies were in mood disorders. Half of the RCTs included less than 30 participants. There were very variable assessment of suicidality, including using one item of a scale, but high variability in dose and route administrations, and very limited number of studies, above 2 weeks. So we actually addressed some of these issues in our study. Yeah, so this study was called KETIS. Was a multicenter study in 7 academic centers in France. The PI was Dr. Mokranaba, who is a psychiatrist at the Academic Hospital of Nîmes. So Nîmes is in the south of France. I don't know if you see my arrow, but it's here. And it was funded by public money. So this was a design, it was a randomized controlled trial comparing IV ketamine to IV placebo. And each patient had 2 IV infusions at 24-hour intervals. So I'm sure many people ask why, are wondering why 2 infusions. Well, at the time when the protocol was written in 2013, it looked like it could be a good idea. So it's the highest scientific answer I can give. No, it's really a study that took a lot of time to start, to be implemented, and it's also the reason we use placebo and not midazolam, because it was designed in 2013. There was a 6-week follow-up. And the main outcome, and it's important, was a remission, full remission of suicidal ideation. It was clear for us that response was not a good measure for suicidal ideation. If people keep some suicidal ideas, it's never a good idea. So remission was defined as a score at the SSI, Beck scale for suicidal ideation, below 3, and the maximum score is 38. And it was designed to assess the effect in the whole population, but also per main diagnostic group. And it was really powered to assess this question. It was not a secondary outcome. And the 3 groups were bipolar disorders, patient with MDD and patient with other affective disorders. There were some secondary outcomes that I will present: short-term tolerance, short-term effects on other clinical measures, and remission rates at 6 weeks. The main inclusion criteria were adults. The threshold for suicidal ideas was quite low. So it was an SSI score above 3. All patients were hospitalized. We excluded patients with a history of schizophrenia, psychotic disorder, schizoid, schizotypic personality disorder, psychotic symptoms at inclusion, substance dependence, recent substance dependence, etc. The rest is quite classical. So this is the trial profile. We recruited 156 patients. 83 were assigned to placebo and 73 to ketamine. And you see the distribution by a diagnostic group. 3 patients discontinued in the placebo arm, so at 72 hours. So for our main outcome, there were 80 patients in the placebo group and 73 in the ketamine. So until week 6, 14 more discontinued in the placebo group and 13 in the ketamine group. So you see that the recruitment took quite a long of time, between 2015 and 2019. This is the population in each arm. We had more females than males, as expected. The mean age was around 40, and patients were quite with a high suicidal risk at inclusion. So, for instance, in terms of SSI score, clinician rated, it was around 20. A little bit less when it was scored by patients, around 70. The MINI evaluated that 86% to 97% of the patient had severe suicidal ideation. We used a visual analog scale to measure psychological pain. It's a score on 10, and you see that median score was 8 on 10. For psychological pain, and most of them had a previous history of suicide. So 85% in the placebo group and 93% in the ketamine. So these are the main results. Overall, at day 3, 63% of the patients in the ketamine group reached remission. And there were 31.6% in the placebo group, so it gives an odd ratio around 4. However, there were clearly differences between diagnostic group, and this is quite new. There was a strong effect in the bipolar disorder group. As you can see, the remission rate was much higher in the ketamine group, around 84.6%, and was also lower in the placebo group, 28%. There was no significant effect in the major depressive disorder group, as you can see here. And there was a trend toward a significant effect in the other affective disorder group. At 6 weeks, there were no more significant difference between ketamine and placebo, but it was mainly due to the fact that there was a higher remission rate with time in the placebo group. Reached 56.3%. As you can see, remission rate remained high in the ketamine group, 69.5%. And these results were unchanged when we controlled for severity of suicidal ideation at baseline, gender, use of antalgic or center. So if we look at these results on a graph, you see this very classical rapid effect after the first infusion in the ketamine group, and that continued until more than 60% at day 3 and was much slower in the placebo group. Other 6 weeks, you have a strong effect initially that pretty much remained, and while the placebo group continues to increase in terms of remission rates. This is the nice picture, the graph, the median graph, but what about individual responses? It looks pretty much like that. So you see that many patients reach remission after the first day, so at D1, 24 hours after the first infusion. But it's interesting to see that some relapsed, even among those, so the blue line is the remission threshold. So among those who reach remission after the first infusion, some, you see, relapse. And other people, it's interesting, reach remission at day 2, so after the second infusion. So it's clearly not a support for the use of 2 infusions, but it could be explained by that. Now, if we take a look at the same results but per diagnostic group, you're going to see that the picture is much different. In bipolar disorder, these 2 exceptions, you see that most patients reach remission, and those who are not in remission still had a strong response and were very close to the remission threshold. This is very, very different in the depressive group, in the depressive disorder or MDD group, and the other disorder group, where you see it's much unclear. Some people never responded at all, not even not to speak about remission. And these are the individual responses when we look at 6 weeks. I wanted to show you that just for clinicians to be very careful. You see that a lot of patients reach remission at day 3 and then relapse. So clearly, continue to keep an eye on patients, even if they reach full remission of suicidal ideas. They can relapse, you see, at day 14, at day 28. Many of them are in this case. So we see a lot of different trajectories following the initial remission. When we look at other clinical measures, so when you look at differences at day 3 between ketamine and placebo arms, there are significant effects on SSI, clinician-rated, patient-rated depression, psychological pain, hopelessness, global clinical impression, but not physical pain, mainly because the scores were quite low at baseline. There was a good tolerance during the first 3 days, classical sedation and depersonalization, but there were no hypomanic episode, no psychotic episode, and importantly, no increase in suicidal ideation, which is something we can observe with some antidepressant the first days after initiation. So importantly, there were unfortunately some suicidal acts during the 6-week follow-up. So we had 1 suicide. A person died between day 3 and day D7 in the ketamine arm. And when we looked at his, he had never reached the level of response at the suicidal scale, the SSI. So at D1, D2, D3. It's much more complicated to understand what happened in the patient who attempted suicide, because 2 actually reached remission and attempted suicide later. 2 were responders, not remitters, but responders, and 1 was non-responder at D3. And the placebo arm, there are 8 patients who attempted suicide. One thing we're interested in is mental pain. There is a large literature showing a close link between psychological pain and suicidal ideation. And what we found is actually when you take into account change in mental pain at D3, the link between ketamine effect and change in suicidal ideation at D3 is reduced. So suggesting that mental pain plays a role somewhere in the relationship between the effect of ketamine and changes or reduction in suicidal ideation. Just to tell you that we use this scale that we developed some years ago, and that is a visual analog scale measuring physical pain and mental pain. Very quick to use if you're interested. There is a English version, I'll be happy to share. Very recently, we assessed, so it's not in the BMG paper, but we assessed the clinical factors that could be predictive of suicidal remission at day 3 and week 6. So we took into account diagnostic group, age, gender, BMI, psychological pain, physical pain, suicidal ideation, patient-rated and clinician-rated, hopelessness, depression, CGI, and the history of suicide attempt. At the multivariate level only, but strongly, there was a strong effect of suffering from a bipolar disorder. So this is predictive of a remission rate of a remission at day 3. And there were 2 other factors that came out that survived, which is having a high level of physical pain at baseline and a low level of suicide ideation according to patients at baseline. None of these variables were predictive of remission at week 6. Okay, so these were the main results from this study. Clearly, a lot remains to be done. And the first thing is it beneficial in terms of prevention of suicidal act? We tend to think that yes, because it decreases suicidal ideation in many patients, but not all patients with suicidal ideation will realize a suicidal act. So are we efficient in those who could realize a suicidal act? We need to show that. We need to power studies to check that. Ketamine has an effect on reduced premature mortality, and what is the cost effectiveness of that? Of course, everybody here keeps in mind the long-term risk. Also, when we come back to the field of suicidal ideation, we were interested in using ketamine in other groups, including borderline personality disorder, schizophrenia, or drug addiction. So what are the risks with ketamine in this particular population? What about old age people and young age people? Treatment administration raised a lot of questions. How should we use it and where? Should we continue to use it only in academic hospitals? Could it be done in licensed consultation where physicians see and psychologists see a lot of patients after a severe suicide attempt, or at day hospitals? And clearly the mechanisms of action on suicidal ideation, not on depression, but on suicidal ideation, needs to be investigated at biological level, at the cognitive level, at clinical level. Also, we talked about the effect of set and settings. It was very interesting to hear about that, because this is clearly something interesting. Regarding cognition, it would be very interesting to see if there are changes in decision-making in patients and in cognitive control, which are 2 of the cognitive function affected in suicide attempters, but not in suicide ideators. We also need other drugs, because ketamine is not effective in all patients. And we have just started a new RCT using buprenorphine. So I'm the PI of the study. It's publicly funded. It's an RCT comparing 2 arms of buprenorphine at low dose, 0.4 and 0.8 milligrams versus placebo, 14 days of treatment. The main outcome is SSI at day 7. We plan to include 180 patients in 9 academic centers. In France, we have started to recruit in September. And that's it. Many thanks to all the people that have been involved in this study, and thank you for your attention.
Thank you very much. Thank you very much. Any questions? Let's start over here.
Hi, Saga from Flexio. I think the question that most people will want to ask, do you have an idea why you have so different results in bipolar and in unipolar? Have you looked at the baseline characteristics of these patients to see if they were different?
No, we could not see any difference that could clinical difference apart from suffering from a bipolar disorder that could explain this huge difference, actually. And it was surprising in both directions. This huge effect in bipolar disorder, but also the lack of effect in MDD was very surprising. I don't know. It's clearly, unfortunately, when the study was designed in 2013, we really target on the clinical aspect. So we don't have biological measures. I'm working on cognition for a long time. We did not do that. We have no MRI, we have no cognitive batteries. And so we have DNA and RNA, so we may have some interesting results there. But yeah, we couldn't find any explanation from the data that are available.
We've got another question.
Hi, from Toronto. Thanks for the excellent presentation. Really interesting project. You mentioned at the end about borderline personality, and it seemed that in your eligibility criteria, that only cluster A personality disorders were excluded, but not cluster B. And I would assume patients admitted for suicidality, a large portion of those may have borderline personality. Do you have a sub-analysis or sense of that group in specific?
No, unfortunately, we don't collected any measure on personality disorders. But you're right that among the population, we have patients with borderline personality disorder. That's clear. But I think we really need to design a study in this specific population because it raises a lot of questions about the use of ketamine. Yeah.
We've got one more question here.
How long have they been in hospital on average?
How long have they been in hospital before inclusion or after the ketamine?
How long had they been in hospital at the point that they were included in the study?
I don't remember them. I cannot answer, sorry. But I think many patients were recruited just after entrance at the hospital, actually. But I'm clearly not all of them. Some were proposed to participate in the study because everything failed. But it's a very good question, but I don't have the clear information about that. Yeah.
So we've got another question here.
Thank you. Wiesław Zuba from Poland, guys. I was just wondering, did you see the effect of the backbone mood stabilizer class as related to the observation in the bipolar patients with regard to the response?
So as you saw, the groups are quite small. It's 20 patients when you divide per arm and per diagnostic group. So it was complicated to do, secondary analysis, differentiating. I saw the table. You can see that there were plenty of medication, categories, but it was clearly not possible to assess. Including interactions with ketamine. That would be very interesting, of course. I think we clearly need to replicate this finding in bipolar disorder. I mean, it's a huge effect. And so I know my friend Mukranaba in Nîmes is preparing a project just to assess the effect on depression in bipolar disorder, because it's very interesting. It seems like a population that responds very quickly. And we need that. We have nothing to treat depression in this population. And of course, suicidal ideation.
Thank you very much for joining us. Thank you once again.